So, a very good evening to all of you. I welcome you to the Masterclass in Hematology, organized under the aegis of the Indian Society of Hematology and Blood Transfusion. Today's topic is interpretation of HPLC, and who better to talk on it but our speaker for the evening. It gives me great pleasure to introduce Professor Reena Das, Head, Department of Hematology, PGIMA, Chandigarh. She is renowned all across the country and indeed internationally for her work on red cell disorders. She's a champion of molecular hematology, but above all that, she's a great teacher, as I can personally vouch, and as I'm sure you're about to find out soon enough. So, without further ado, I invite Professor Reena Das to take on a masterclass on the interpretation of HPLC. Over to you, ma'am.
Thank you so much, Nabajit, for your very kind introduction, and I hope I can keep up to the expectations. Anyway, so today's class is on HPLC, and before going to HPLC proper, I thought that we'll just recapitulate the classification and the spectrum of the thalassemia and hemoglobinopathy disorders. So when we say thalassemias, what we basically mean is that the globin chain quantity is reduced. So in other words, we say this is a quantitative disorder where whichever globin chain is defective, we call it that type of thalassemia. So if it is a beta chain defect, we call it a beta thalassemia. And if it is an alpha chain defect, we call it an alpha thalassemia. If it is a delta beta type of thalassemia of a deletional type, then we call it a delta beta thalassemia. So when we talk about the thalassemias, I said that, beta thalassemias could be beta 0 when you actually get no output at all. So the beta chains from our two alleles actually have no output, and we say beta 0. If some output is there, we call it a beta plus. And if a little more output is there, but not quite normal, then we call it beta plus type of a defect. Now, hemoglobinopathies are disorders which are qualitative disorders. So what do we mean by that? That the hemoglobin is fine, it is there, but then the hemoglobin quality is not the same, which means that disorders like hemoglobin E disorders, sickle cell disorders, they can be classified as hemoglobinopathies. And the third condition which is there is high fetal hemoglobin. Now, high fetal hemoglobin disorders are actually not abnormal hemoglobins, because we know that normally the fetuses have high fetal hemoglobin. And in fact, the property of high oxygen affinity of the fetal hemoglobin is there. But when you get high fetal hemoglobin in the adults, then we call it an inappropriate expression. That means it is being expressed at a time when it shouldn't be expressed. Now, these three disorders, the thalassemia syndromes, the hemoglobinopathies, and the high fetal hemoglobin disorders, these are inherited as autosomal recessive conditions, which means that both the parents would be definitive carriers. Then you get there is a 25% chance in each pregnancy that the baby can be affected. Now, these other disorders, which are these unstable hemoglobins, where there's an abnormal protein, or polycythemic variants where there is a gain of function or an unusual property is acquired, such as methemoglobinemia, these are sporadic hemoglobin variants, and they are usually inherited as autosomal dominant conditions. So let us remember that thalassemias we have to remember as quantitative disorders. Hemoglobinopathies, we call it a qualitative disorders. You can have combinations of thalassemias with hemoglobinopathies, and I'll show you some examples. And these are predominantly autosomal recessive disorders. So these are the basic things to remember. Now, when we talk about the high performance liquid chromatography, this is an cation exchange kind of a HPLC which is there. Now, what do we mean by that? Basically, we have the HPLCs are such that this is basically a separation method, which is based on different interactions of the specimen compounds with the mobile phase at high pressure and with the stationary phase. So I'll show you figures so that you can understand what is actually written over here. So as the compounds travel through a supporting medium, which is actually a column which is negatively charged, you will find that different subcomponents of the hemoglobins will get eluted out, right? So the compounds which are interacting more strongly with the stationary phase, which is our column, are going to be retained for a longer time in the medium than those that favor the mobile phase. And the concentration of each detectable compound which is eluting from the column is a function of time. So what do we mean by all these specific things that are written on this slide? We'll just go by we have the basic components of the HPLC. So basically, we have different types of buffers. There are two elution buffers which are there. There is a pump which is going to, take into account that which buffer, how much of which buffer is actually going through. There is an injection valve, there is a cartridge, there is a detector, and there is a chart recorder, right? Now, all this is basically depends on the interchange of the charge groups on the ions on the exchange material with the charge groups of the which are there on the hemoglobin molecule. Now, so what is actually happening in this cartridge is that you have a subcomponent. So this is just a diagrammatic representation showing that the blood actually has different types of hemoglobins. So we know that adults predominantly have adult hemoglobin, which is roughly about 95 to 96%. Hemoglobin A2 is a minor component, and the hemoglobin A2 is usually less than 3.5%. So roughly we say 2 to 3.5%. And then we have very little component of the fetal hemoglobin, which is usually less than 1% in the adult. So what happens is that these two elution buffers that I was talking to you about, there is this elution buffer 2, which keeps on increasing with time. So it starts with elution buffer 1, and the percentage of elution buffer 2 keeps on increasing. And as the ionic strength increases, the more strongly retained hemoglobins are going to get eluted out, right? So ultimately, how does it look like? It looks like this, that, depending on the charge and the type of hemoglobin, something will pass through and something will get attached. Depending upon, you see this hemoglobin component is going first, right? And this is how it'll happen like this. So one after the other, it'll keep on going like this, right? So this is just a diagrammatic cartoon to show what is exactly happening and which buffer is going through. Then you have these fractions which are detected as they pass through an UV light or a visible light detector. These are recorded as an integrating computer system. And what do we get? We get the analysis of the area under these absorption peaks, which gives us the percentage of the fraction which is detected. So this is just to show you how it is going through and what is actually getting recorded. And these are known as retention time. Now, this is how the instrument looks like. So the instrument has the processing unit, which is known as the sampling station. And the variant 2 sampling station is known as VSS. And what is getting analyzed as peaks over here, you can see this is the analyzing unit. Basically, the computer has a clinical data management software, which is known as the CDM. What is important to remember is that between each run, the sample injections, the sample needle has to be rinsed and washed with the solution so that there is no sample carryover. I'll briefly show you an example of how sample carryover looks like. Now, what are the guidelines for the interpretation of the results? You have to observe the following guidelines to assure acceptable results. The variant 2 must pass calibration, and I'll show you the picture of how calibration looks like. The retention time for the hemoglobin A2 in the calibrator is between 3.65 plus minus 0.1. Now, this is a very specific kind of a retention time which has been given. So the two major important components that we are looking at the HPLC are the hemoglobin A2 percentage and the fetal hemoglobin percentage, right? And these are the calibration factors which we have to adhere to. If it passes through the calibration, so each time the machine is run, you have to use the calibrator, right? Total area of each analysis should range from 1 million to 3 million microvolts per second, and results should not be interpreted or reported if the area is outside this range. This is also important to remember. In practical experience, actually, when we run it many times, we really don't find too much problem because of this. But this is what the manufacturers have said, and we should adhere to that. Quality control values should be in range. So each time that we run it, we must use quality control samples, which are given by the company. And this is giving you the total adult range of hemoglobin A2, which is there. And I'll show you examples of these, right? So now this is how a calibrator data looks like. So the first thing that we do is look at the calibrator, and the calibrator has to be run every time, like I told you. The fetal hemoglobin and the hemoglobin A2 percentages have a very, very tight range, right? And the calibration, the RT is called as the retention time. And the retention time is 3.65 plus minus 0.1 minutes. So if you look at the retention time of hemoglobin A2 here, so here you can see it is 3.66. The other important thing to remember is that actually the reading actually starts from 1 minute onwards. And so we usually don't interpret the peaks which are, or the percentages are not interpreted, which are before 1 minute. The other thing to note are that the fetal hemoglobin and the hemoglobin A2, these two are shaded in gray. These two are the most important components that I told you. And the third thing to remember is that the intervals between each run, so basically one sample takes roughly about 6 minutes. So you can see here that the time which is being shown 1 minute, 2 minutes, 3 minutes, 4 minutes, 5 minutes, 6 minutes. And in between there's a washing period. So roughly about 9 samples can be done in 1 hour's time. After the calibrator has passed through, we have to use two controls. One is known as the low control data, and this is actually normal control. So they call it low control data. I always say that this is normal. And what is normal over here is that the A2 percentage is in the normal range, right? And this is the total area that we were talking about, that the area has to be within between 1 to 3 millions, right? Then we have the high control data. So high control data, again, here we have a tight range of the fetal hemoglobin and the hemoglobin A2. Now, the most important things to note in the HPLC graphs, like I told you, are the fetal hemoglobin, which is the first peak over here. Then comes the adult hemoglobin. Then comes the hemoglobin A2 peak. And the last peak, which is very important, is the sickle peak, right? So the high control actually has all the 4 important components which we are looking at in the HPLC. If your calibrator has gone through well, and your controls are working properly, the normal and the high control, now you have to run your test samples. So this is another view of the hemoglobin HPLC. Now, what are the advantages of a hemoglobin HPLC system? It's a fully automated system. There's good speed accuracy. You have to use calibrators and controls. And this is how the normal graph will kind of look like, right? So you have the fetal hemoglobin concentration, which is given here as 0.2%. And this is also written over here. So in the calibrated areas, you can see that the fetal hemoglobin and the hemoglobin A2, these two values are written here, which has been reported again here. So where are we reporting actually is the peak area which comes here. So you can see A2 3.59 minutes over there. Now, just to remember that as a principle, if you get a normal HPLC, nothing needs to be done. Only thing that you have to remember is that you have to ensure that the sample is a pre-blood transfusion sample. So by chance, if the patient has received a transfusion, then you will not be able to interpret this report as a normal report. Again, as a principle, if you get any abnormal peak, it is important that you use some other alternative method to confirm that this is that particular peak. So what we usually do is that if we get an abnormal peak on the HPLC, usually we back it up with the hemoglobin electrophoresis, and this hemoglobin electrophoresis is usually done at the alkaline pH. Earlier we used to do it, sometimes we need to really do it in acidic pH, but now the circumstances are fewer where we actually run it on the acidic pH. So this is showing you the HPLC of a beta thalassemia trait. And here the normal values of hemoglobin A2s are given over here. So roughly about 2.3 to 3.5% is normal for our lab. We call it from 3.6 to 3.9%, we call it borderline hemoglobin A2. Now, when the hemoglobin A2 is 4 or more than 4%, then we call it a beta thalassemia trait. Though I have written over here as 4 to 7%, sometimes regular beta thalassemia traits can have hemoglobin A2s going up to even a little more than this. Now, in thalassemia major, what happens is that you will find that the adult hemoglobin is very little, and the predominant peak which is there is that of the fetal hemoglobin. Now, when we are talking about these hemoglobin subcomponents, it's important to remember that the instrument actually has been fed data where it has been given windows. The window from this time to this time is supposedly fetal hemoglobin. And occasionally you can have different types of hemoglobins, which are actually getting masked among these peaks that we see. And I'll show you examples of those also. Now, the other thing also to remember is that I told you that before 1 minute, we really don't do interpretations directly, but we really do look at the graph over here. Now, in this particular case where the fetal hemoglobin is high, you will find some peaks over here. So multiple peaks over here, which are very typically seen with high fetal hemoglobin. These are basically the glycosylated or glycated or, different types of subcomponents of fetal hemoglobin. I'm not remembering the exact terminology, but so basically, this is when it's fetal hemoglobin, you will see these peaks and you just ignore it. Now, if you see peaks over here and the fetal hemoglobin is low, then they become really significant, right? And I'll show you examples of those also. So when we talk about the thalassemias and hemoglobinopathies, the important things to remember are that it is one of the most prevalent disorders among inherited conditions. It's also one of the most easily preventable genetic disorder, which has a lifelong morbidity and a relatively early mortality. Now, what do I mean by that? That patients with thalassemia major, they have a lifelong morbidity, and they can have a relatively early mortality because of various complications. But we are not going to talk about the clinical things here. We'll concentrate on the HPLC graphs only predominantly. Now, the other thing to remember is that when we are reporting the HPLC graphs, we take help of these automated blood cell counter values, and these kind of help us because in usual beta thalassemia traits, you will find very typically the RBC counts, the hemoglobin may be normal. Usually it is normal, but maybe mildly reduced also, like it is shown in this particular example. It's 9.6 grams %, and RBC count is usually increased. The MCV is typically reduced. We know the normal range is from 80 to 100. So here, 80 to 100 femtoliters, usually MCV will be reduced. Now, if you look at the red cell indices, a beta thalassemia trait, I told you, will have hemoglobin more or less normal. RBC count will be increased. Mean corpuscular volume will be reduced. Mean corpuscular hemoglobin will be reduced from less than 27 picograms. If you look at iron deficiency anemia, hemoglobin will be reduced in iron deficiency anemia. All these other parameters will be down, and the red cell distribution width will be increased, which is going to be normal in a beta thalassemia trait. Now, what generally happens in our population is that we can get beta thalassemia traits who have iron deficiency anemias, and your red cell indices may not be very, very typically seen. The other problem that we encounter is that red cell indices should be interpreted with caution during pregnancy, because we know that you can get various types of nutritional deficiencies as well as other, dilutional anemias, etc. Also, just to remember that the beta thalassemia traits have these red cell indices where RBC count is increased, RDW is normal with hypochromic microcytosis. In an alpha thalassemia trait, also you have similar red cell indices, but the frequency of alpha thalassemia traits is much higher. So we say in India, the average percentage of beta thalassemia traits, there are regional variations, of course, but is roughly about 4 to 4.5% if we take all over India. And the frequency of alpha thalassemia traits are about 12 to 13%, which is an average all over India, where you get single alpha gene defect. So if you look at the red cell indices and you predict as a pathologist maybe that maybe this is likely to be beta thalassemia trait, and if it turns out to be a normal report, do not be disappointed. You still have made a very good observation, because these are very typically seen in a beta thalassemia traits. The other thing to remember is that the red cell indices you will not be able to pick up the hemoglobinopathies like sickle cell disorders or hemoglobin E disorders or combinations of various types. So that's why we say that if we have to screen, but just by red cell indices, you will be able to pick up many cases or more cases of beta thalassemia traits, but you may not be able to pick up all the types of hemoglobinopathies. And probably that is the reason why we advocate that during pregnancy, it's a good idea to do HPLCs of all antenatal women, because it is a test which varies from something like maybe the cost is about 200 rupees if we are running the test, but then, it can go up to maybe 700 or 1,000 in the private sector. And it is still worth it to do it when the woman is pregnant. At least once, everybody should get a screening done. And that I would like to advocate, of course. There is a app which has been, designed, and we have kind of collaborated with this Aalborg University, where this is an app on the Google Play Store on your Android phones, where you can, download this freely, enter the values of hemoglobin, MCV, MCH, RBC, and RDW, and you'll get results like this, that suspected to be beta thalassemia trait, HPLC is recommended. You could also get an output which says not suspected to be beta thalassemia traits. And this app has been made by data in thousands that we have given to them, so that they're able to build this app, and you could, download and see. However, just remember that there are some diagnostic caveats of beta thalassemia traits or even thalassemia major. There could be red cell indices which may be normal in a beta thalassemia trait, and there could be various reasons for that. At the time of referral to a hospital, a child with thalassemia major may have already received a blood transfusion, and in such cases, the HPLC will appear to be normal. And therefore, you may need a molecular confirmation, because even if both the parents are beta thalassemia traits, to give a definitive diagnosis, molecular confirmation may be required. Molecular confirmation may also be required definitely when you are advising prenatal diagnosis. Now, what are the problems that we encounter? This is just giving you a snapshot of the database of human hemoglobin variants and thalassemia mutations which are there. Look at the entries which are there. So many different types of substitutions and variants which are there. Now, and when we look at the HPLC graph, you can see that in 5 minutes or maybe 4.5 minutes, we are expecting the instrument to give us all the different variable types of hemoglobin disorders which are there, which is a problem, right? So we'll just go through what are the problems which are there. So this is the first case. 25 years female with mild pallor. She has presented to the antenatal clinic. I'm giving you mainly examples of antenatal clinic because what is the advice that you're going to give in a case? That is what is important for us, right? So there is mild anemia, there is some hypochromic microcytosis, RBC count is reduced, and the RDW is slightly increased to 17.5%. Now, if you look at the HPLC graph here, you can see that the A2 concentration is 29.1%. And this is kind of increased. The fetal hemoglobin is more or less in the normal range, less than 1%. Adult hemoglobin is fine. Now, this is increased. This is definitely more than the beta thalassemia traits that we would get. So this is actually a case of hemoglobin E disorder, where this is a hemoglobin E trait. Now, this is the possibility which is there. How will you confirm it? You need to do an HB electrophoresis. So if you don't have the HB electrophoresis and you see this kind of percentage of about 25 to 30% of hemoglobin A2, you can give a report of suspected to be a case of HBE trait, right? And because she is from the antenatal clinic, it's important that you advise that the husband screening should be done. And you know that hemoglobin E disorders are actually a beta type of defect. So in beta defects, the percentage should be higher of the abnormal hemoglobin. It should range from 35 to 40% probably. But in hemoglobin A2 disorders, it's slightly an unstable type of an hemoglobin also. And that is the reason why the concentration of hemoglobin A2 is a bit on the lower side. It is roughly about 25 to 30% or so. So that's why in hemoglobin A disorders, we call it thalassemia hemoglobinopathy. So I told you something is there, thalassemia, there is hemoglobinopathy, and hemoglobin E disorders are called as thalassemic hemoglobinopathies. So just to remember that if you get HPE disorders like this, you should ask for sibling screening. You should also ask for the screening of the husband, and the husband screening is most important because time is precious during pregnancy. Now, this is
Can
another
I stop you
example.
for a moment? I think there is one attendee who has raised their hand and probably needs to ask. You can see
Yes,
Dr.
please.
DK Mazumdar has raised the hand. Can you maybe type in your chat or type in your question? Or maybe we can allow him to speak. Can the Riverwood guys help with this?
Hello, ma'am.
Hello. Hello.
Ma'am, this is Dr. Prerna from SMS Medical College.
Okay.
Ma'am, I have a question about the beta thalassemia trait and iron deficiency anemia.
Okay.
Many times we get cases where RBC count is high and RDW is also high and MCV is low. So we think that both these conditions are probably there. So is there any guideline when we should do HPLC in such cases?
So HPLC, I think if the woman is pregnant, please do HPLC straight off. And when there is any doubt of any time. So as a pathologist, actually, if you look at the red cell indices and you suspect beta thalassemia trait, it's a good idea to put it in the advice. Because when you're examining the red cell indices, it's an opportunity for you to advise at least that it should be done. Whether the clinician sends it or, that is their prerogative. But at least from our side, we should advise that a screening should be done.
Ma'am, actually, I have read somewhere when iron deficiency is there, then HbA2 might come lower. That's why I asked this question, ma'am.
So that's a very relevant question that you have asked. And we have actually done a study here where we looked at the iron parameters of all the parents of thalassemia major. So these are like obligate carriers in whom we had done the iron parameters, and we found that the cases, even when there was severe iron deficiency anemia, the A2 did not reduce to the diagnostic level, which means the A2 was more than 4%. So maybe, if you have severe iron deficiency anemia with beta thalassemia trait, your A2 may be slightly reduced, but it does not fall below the diagnostic range for you to have confusion. So it's a good idea to do the HPLC at that time.
Okay, ma'am. Thank you.
So this case 2 is a 22 years female with moderate pallor. You can see that the hemoglobin is 8.7 grams %. And here you can see that clinically this patient is symptomatic. Though she has come to the antenatal clinic, she has required a blood transfusion at the age of 14 years. Now, when you look at the red cell indices, there is significant hypochromic microcytosis, and the red cell distribution width is quite increased, 22.5. So you can imagine that there would be a lot of anisopoikilocytosis. Now, when you look at the graph here, you can see that the hemoglobin A2 percentage is quite high, 71.7%. And the fetal hemoglobin is also high. So each time you see the fetal hemoglobin high, you please note here also that you have these peaks over here. So in this case now, again, you would think that what are the possibilities? The major possibility, of course, is that this is possibly a combination of beta thalassemia with hemoglobin E disorder, right? So either it's a homozygous E because the A2 concentration is high, but then the homozygous E patients, individuals will not present with symptoms. Mostly they will remain asymptomatic. So here we have a woman who has had mild pallor and jaundice for the last 12 years, required a transfusion. So she has been symptomatic, but she's behaving like a thalassemia intermedia kind of a phenotype. So just to recall that hemoglobin E with beta thalassemia, when you get this combination, the patients can behave in a very wide spectrum. You have patients who behave like typical thalassemia majors, or you can have very mild presentations also. That would actually depend on whether the patient has what type of beta mutation, also what type of alpha gene defects may be there in that particular individuals, what is the X-min status. So there are multiple things which could be contributing to the clinical phenotype of the patients. And I'm sure that you would have seen all these examples if you look at patients with thalassemias. So what we usually do is that whenever we get a peak, I told you that this is the alkaline pH electrophoresis, and this is the point of application here. And in this particular case, so this is a hemoglobin A2 region band. So you get a thicker band here because of the increased amounts of hemoglobin A2 or hemoglobin E, actually. So, since we have this electrophoresis here, that if you get a peak over here, this peak is actually, this band is actually of either hemoglobin S, sickle hemoglobin, or hemoglobin D Punjab, or if it's a fainter band like what you're seeing here, it could be hemoglobin Q India. So Q India will have a lesser quantity because it's an alpha chain variant, and this is the position that you will get. We really don't have any example of a fast moving band here. So when we talk about the hemoglobin E and high hemoglobin A2 disorders, so I showed you hemoglobin E trait. I also showed you a double heterozygous for hemoglobin E and beta thalassemia. The previous one, there the hemoglobin A2 percentage was, adult hemoglobin percentage was less. So this one probably some transfusion must have been given some time back. That's why you have some amount of adult hemoglobin which is there in this particular HPLC. Now, this is a HPLC of a hemoglobin D Iran, and you can see because hemoglobin D Iran is an asymptomatic type of a hemoglobinopathy, which is typically seen more commonly towards North India in our region where we are staying, Chandigarh and all, we do see some cases of hemoglobin D Iran. So the peak is almost in the same region, but you can see that the base is a little more wider. The quantity is a little more compared to the hemoglobin E trait, right? And here you can see, like I told you, it's in beta chain variants. Usually it is in the range of 40 to 45%. So here D Iran is in the range of 42 to 45%. And hemoglobin E trait, like I told you, will be a little less because it's a thalassemic hemoglobinopathy. So what will you advise for hemoglobin D Iran? Nothing needs to be done. You don't even have to advise screening of the husband. So basically, as pathologists, we just have to know the combinations where we need to advise for screening of the husband or the family members or situations like that, and where we don't need to advise anything. So if you get a situation where is actually you get hemoglobin D Iran trait with hemoglobin beta thalassemia trait, that would get complicated because there you will not get adult hemoglobin. You will get just a very broad peak of a very broad band of hemoglobin A2. And if you get that, then it's very important that you do the hemoglobin electrophoresis. Otherwise, you could make a mistake and say that this is actually homozygous HPE disorder or something like that. So those are some situations where we would like to avoid and do one electrophoresis if possible. If you don't have both the setups, like in our lab, we have the HPLC, also we have the electrophoresis system. But if you don't have that, you should at least in the advice say that this is advised to be done, and the patient at least can get it done from some place. So like I showed you in the previous one, that A2, if the peak comes in the A2 region, the band comes in the A2 region, it is E trait. And if it comes in the SD region, then this is a hemoglobin D Iran trait. So what is the effect of carryover sample? So here you can see this is a case of homozygous HPE disorder. And here the A2 percentage is 91.5%. Now, the next sample which is run is actually just a normal sample over here. So the percentage of A2 is 2.8%. So, but whenever you have got an abnormal hemoglobin and you run the next sample, it's important to rerun the next sample again so that there is no carryover. Now, what has happened in this particular case is that we have rerun it, and you can see that the A2 concentration has dropped from 2.8 to 2.5%. So the difference is only 0.3%. So probably will not make a difference when it is a normal person. But if it is a trait and or a borderline kind of a situation, say it is 3.8% borderline case, and because of this carryover effect, it becomes 4.1%, and you call it a beta thalassemia trait. So you can make an error there. So it's important to just remember and train your technical staff that whenever you get a abnormal hemoglobin peak, you must rerun the next sample again so that you get an accurate percentage of hemoglobin A2. This is another case where this was a 27 years male who presented with history of mild pallor to the emergency with chest pain. And if you look at the red cell indices, this is what I wanted to highlight here, that the MCV, MCH is slightly reduced, but MCV is normal, and the RBC count is on the lower side. RDW is increased. So when we looked at the HPLC, you can see that the A2 is 3.9%. There is no adult hemoglobin. The fetal hemoglobin is 36.9%. But what is important to remember is that there is this S window where you have got 54.2% of the abnormal hemoglobin. So it is likely that this case is some combination of sickle cell. So it's one of the sickling hemoglobinopathies which is there. And in such situations where you have a borderline kind of hemoglobin A2, it becomes a bit of a problem because sometimes some adducts of sickle can also get into the hemoglobin A2 concentration. And that is why if you get a situation like this, you know it's a sickling disorder, but it's very important to fall back upon the family. That means do the parental screening. If you do the parental screening, immediately you'll come to know whether you're talking about a homozygous HBS condition or whether this is a double heterozygous condition with one parent being a beta thalassemia trait and the other parent being a sickle cell trait. So it's important to differentiate these two situations. Because it has some connotations for prenatal diagnosis as well. So what will you advise? Advise, of course, the sickling test that will confirm, but you already have an idea that the sickling is there. So advise parental screening, that's important. And because he's 27 years male, probably whenever he gets married, his wife also needs to be screened to see whether she is normal or she is a sickler or a beta thalassemia trait. That would be important to check. So this is just showing you the different types of HPLCs that you are likely to get. So this is a sickle cell trait. Very typically, you just this HBS window, it has about 37.1%. This is a homozygous sickle cell disorder where the S percentage is 75.8%, but the fetal hemoglobin is increased here. The adult hemoglobin is hardly there, right? So if you look at the parents, you will find that both of them are sickle cell trait. Now, this is a double heterozygous for sickle and beta thalassemia, because here you can see that the A2 percentage is 5.2%. So clearly the beta component is there. And another situation where the HPLC is quite diagnostic is a double heterozygous state for sickle and hemoglobin D Punjab. So actually hemoglobin D Punjab is roughly about 2.5 to 3% in our population as a trait. By themselves, they are completely asymptomatic and nothing really goes wrong in them. But if they get married to a sickle cell trait disorders, then the child can have a significant sickling syndrome where, this kind of graph will be there. So the first peak over here is that of the D window, which is 43.6%. And the next peak is that of a sickle. So it's fairly simple by HPLC. If you have seen it once, you should be able to pick it up. And these disorders usually have slightly increased fetal hemoglobin. So the sicklers, which are from India, they usually have a higher fetal hemoglobin compared to the sicklers in Africa. And this probably helps us. The higher fetal hemoglobin, which is there in our population, actually gives rise to a more milder kind of phenotype compared to the sicklers in Africa. So this is another case history where it's a 25 years female sent for thalassemia screening, hemoglobin slightly reduced, but there is hypochromic microcytosis. So if you look at the red cell indices, the MCV is reduced, The MCH is also reduced, the RBC count is increased, and the RDW is more or less within normal levels. Now, when we look at the HPLC graph over here, you can see that the D window is showing 87.5%. So there is a predominant peak which is there of the D, and there's no adult hemoglobin. Now, what is important to remember here is the A2 concentration. The A2 concentration, you can see, is within the normal range of 2.5%. And when you get hemoglobin D disorders, this is notorious as a condition to give rise to falsely low hemoglobin A2. Right? So this is something you should remember, that if you get a peak like this, which is predominantly showing you D, and the A2 looks normal, look at the red cell indices. If there is hypochromic microcytosis looking like a beta thalassemia trait, please ask for parental screening, and more likely that this is a double heterozygous for beta thalassemia with hemoglobin D disorder. So that is very important to remember. Now, this is another condition which is there where you get a peak here. You see, this is given as an unknown peak of 11.9%. So this is a fast moving kind of a peak which has come here. But on electrophoresis, this is like HBQ India in the HBS and D region. But this is not important because this variant is an alpha chain variant. So we know that normally adults have 4 alpha chains, normal adults. So if there is one alpha chain which is defective, like in this case, roughly it is about 25%, which will be the abnormal component. But usually with hemoglobin Q India, it is a little reduced. But here, this part is important to notice. So if you get cases of Q India, look at the hemoglobin A2 percentage. Here, the A2 is 4.6%. And because it is 4.6%, this person is a double heterozygous for HBQ India with beta thalassemia. And here you have to advise screening of the husband. So if you see Q India and you see A2, which is normal, nothing needs to be done. But if you see Q India with A2 raised, please ask for screening of husband. The Q India is not important. What is important is that the person is a beta thalassemia trait. This is again the similar kind of example. You can see in this case that the A2 is 4%. So going up to the beta thalassemia trait-like condition. But in addition, there is an increased P3 peak. This P3 peak of 23.6%, this is more likely to be hemoglobin J mirrored. And when you do the electrophoresis in a case with J mirrored, you will find a fast-moving band which is there. So it will go even faster than hemoglobin, the adult hemoglobin. And here again, the advice should be screening of the husband. The hemoglobin J mirrored is not important because that is an alpha chain variant. But what is important is a beta thalassemia trait. I think I have kind of come to the end of the time which is there. I have many different kinds of HPLC graphs which are there, but then because of the time constraint, I think we'll leave it till here and we'll take questions, I think so. This is just one example of how the child's HPLC looked like a thalassemia major, but when we looked at the father's HPLC, we found that the father was a case of hemoglobin Lepore. So when I showed you the hemoglobin E peaks in the A2 region, I showed you hemoglobin E and I showed you hemoglobin D Iran, but I did not show you hemoglobin hemoglobin Lepore. And hemoglobin E Lepore, when you look at it, the base looks quite wide and it is more triangular kind of. So when you look at the HPLC graphs, actually, all the things are important. Where the peaks are, what is the percentage of the abnormal component which is there, and also what is the shape of the peak. All the three things are kind of important. And for as a pathologist, we have to kind of just remember the various combinations which are important. So just as a blanket, remember that hemoglobin A2 percentage is very important. The fetal hemoglobin percentage is extremely important. And the clinical phenotype is very important. So how is the patient presenting? How far should we take it? You know, like what all should we do in addition to just the HPLC? What advice should we give in each case? Those are important things to remember. I'll be happy to take questions, and if there's anything specific, I have got multiple HPLC graphs, and if there's anything specific you want to see, I can show you.
Thank you so much for that wonderful talk, ma'am. It was indeed a masterclass, and I'm sure the attendees are enriched by the knowledge that you have shared with them. I'm sure they must have especially enjoyed the wonderful cases that you illustrated. I can't really see any questions in the chat box at the moment, so I encourage all participants to please type in their questions in the chat box. But I do see a few hands raised, so I'd request the team, persons from the River Route team, to please unmute people who have raised their hands. I can see Professor P.K. Majumdar has raised his hand. Maybe you can talk, sir. Ask the question.
Ma'am, what is your experience with alpha thalassemia screening in the neonates, ma'am?
We don't do alpha thalassemia screening in neonates. Actually, alpha thalassemias, are you talking about hemoglobin Barts or something?
Yes, ma'am.
So the frequency of hemoglobin Barts is extremely low in India. Alpha 0 thalassemias are pretty uncommon. What we do get is, and I'll just show you, how hemoglobin H looks like. So this is how HBH disorder looks like. You could get various types of problems in the peripheral smear of an isopoikilocytosis. You'll get this on a incubated reticulocyte preparation. You'll get this HBH inclusions, and you will get these twin peaks. So I had told you initially that less than 1 minute, do not interpret anything. But especially if the fetal hemoglobin is high, do not interpret. But there are two things that you can interpret, is that if the patient has significant jaundice, you will see a sharp single peak over there. And if you don't get high fetal hemoglobin, which is the example that I'm trying to show here, that the fetal hemoglobin is very low, but you've got twin peaks here. This is a very important feature that is there with HBH disorder. So neonatal screening for alpha thalassemias are not really relevant for India, because alpha 0 thalassemias are not very common. Alpha 0 thalassemias are more common in the Vietnamese population, Southeast Asia, like that. And since I'm just showing you the graph of an HBH disease, the other thing to note here is that the A2 percentage is reduced. So you can see that the A2 is 1.3% in this particular example. And so if you get typically these twin peaks, low fetal hemoglobin, and the decreased amount of hemoglobin A2, then you should think of HBH disorder. And to diagnose them and go further, then you'll have to do molecular confirmation, trying to do either gap PCR like this. This is just showing an example of gap PCR, or you might have to do MLPA-like procedures, and sometimes, end it up with sequencing, which has to be a specific sequencing of either alpha 1 gene or alpha 2 gene. Neonatal screening usually is done for sickle cell disorders in certain populations, but not really for alpha in India.
Ma'am, we get many newborn samples where the MCV is low. So I was just, because of that, I was just reading about it, that what all tests should be done on those cases.
So, iron deficiency anemia is so common, and there's no real hurry at that particular time to do the screening. You can do the screenings when, everything kind of stabilizes and normalizes, unless there's some kind of research project that you're doing probably.
Thank you, ma'am.
Thanks for the question, Dr. Prerna. Dr. Gopinathan, would you like
to?
Yeah.
Yes. Thank you, ma'am. Thanks for the very nice lecture. Ma'am, I have a small query. In which cases do you find HPLC may not be confirmatory, or you need further evaluation? Like, what are the limitations that you find with HPLC, like in that way?
So I told you that, when you are looking at the HPLC, so let me show you some graphs since you are specifically asking this question. So I'll just show you some examples here. Now, I see this HPLC and I say that this looks normal. Do you think this is a normal HPLC?
No, ma'am.
So what is abnormal here?
Actually, the retention times are quite closer here.
So you think retention. So, okay. Now look at this. This is the normal HPLC. Now, what has happened here is that, it looks more or less fine, but it is not fine. And this is a very subtle difference which is there, right? So you look at the graph, the peak, the graph, the way it is, it's a little broader. And this midline is actually coming to 2.48. Now here it is 2.39. So this was actually a case of hemoglobin Chevrolet, some the oxygen during this is not high oxygen, low oxygen affinity.
Low affinity hemoglobin.
Yeah, low affinity, kind of. But you can get in, because I was telling you, in roughly in 3-4 minutes time, all the graphs are there of all the hemoglobins. So masking is very, very common in especially the unusual hemoglobins. Regular cases, we need to just remember that what are the important ones for us. So for us, mainly the thalassemia syndromes, the hemoglobin E disorders, the sickles, those are kind of important for us. And if we get the other different asymptomatic hemoglobinopathies, which we are able to identify on HPLC, we probably need hemoglobin electrophoresis or some other method. But the ones which are actually getting masked there, it's very little that the HPLC could do for you.
Thank you, ma'am.
Thank you, Dr. Gopinathan. Ma'am, the tiny C window peak here, is it a carryover?
It's not a carryover. It's because of this abnormal hemoglobin only.
Okay.
But when you're reporting one after the other, it would be very easy to miss. Now here, actually, this particular case was picked up by the clinical internal medicine resident, who kind of kept on pestering me that please do something more, because this patient was kind of not too bad, but the oxygen saturation was very low. So what is the reason for that? And when we were kind of just investigating the case, we found that, this abnormal hemoglobin came on sequencing, which I had no clue about. And it was just that, that resident was very persistent. And then I kind of forced him to write up this case and say that, this, since you pestered me to solve this case, you have to write up this case. So the important thing in this family was that all the 3 siblings showed the same features, and basically they need to be aware that if they reach the emergency area, that their oxygen saturation is going to be low, and that's just because of this abnormal hemoglobin and not because of any other problem.
Madam, while seeing the peripheral smear, when should we suspect the thalassemia trait?
Thalassemia traits, you will not be really able to pick up on the peripheral smear. And the reason for that is because a typical beta thalassemia trait, there is hypochromic microcytosis, but it looks uniform because the RDW is kind of normal. So if you look at the smear, you'll find it difficult. You will be able to pick up when you look at the red cell indices, because, on the slide, you may not be able to really pick up anything.
Yes, sir. We have the hemogram along with the smear. So in the rule of thumb is one important this one which we have to look for, isn't it, madam?
Erythrocytosis.
Erythrocytosis. So how much should be the erythrocytosis? Is there any cutoff or?
So what I normally do in my practice is that when I look at the red cell numbers, I look at the hemoglobin, because the red cell. So when we look at the normal kind of a smear, say somebody has got a hemoglobin of 12 grams and it is a male, you expect your RBC count will be somewhere around 5 million or so, something like that. So if you get it in more than that, then you suspect that this is a beta thalassemia trait. But more important than that also is probably the hypochromic microcytosis. Most of the cases of beta thalassemia traits, you will find hypochromic microcytosis. So that's why the red cell indices are quite important.
Okay,
And
madam. So
particular
even
level-
at 12 or 13, even at 12, 11 or 12 HB, if we see microcytic hypochromic blood
Yes.
picture and
Yes.
mild, even if it is mild erythrocytosis, we have to suspect it.
That's right. That's right.
Okay, okay. So the INDU3 rule can be just altered, like hemoglobin is 12 and the RBC count is 5 million, 6 million, like that, or 4 million. 4 million is incorrect INDU3.
Yeah,
So it's
4
just
million would
million.
be fine. I wouldn't really
Fine.
suspect beta thalassemia.
Okay, okay.
That's right.
Just little bit raised is also problematic.
Yes, yes.
Okay, okay. Thank you so much, madam. Thank you so much.
And in between, if this person also has iron deficiency anemia, then this raise is not going to be so apparent also.
Yeah, yeah, yeah. Okay, okay. Thank you so much, madam.
Ma'am, I would like to ask a question, please.
Yes, please.
My name is Dr. Wasi, and my question is that at times we receive patients who have been advised HPLC, but they have recently received a red cell transfusion, and we are not able to do HPLC. So my question is, how much time do you recommend should pass before we should be able to use HPLC for the diagnosis?
For a diagnostic HPLC, I think the rule of thumb is that you have to wait for at least 3 months, because we know that the RBC lifespan is roughly about, we say average is 120 days. Now, if the patient has received a transfusion, even if the RBC is lifespan is not 120 days, it's 90 days or something, it is like you have to wait for that much time. Now, if the patient is a case of thalassemia major, we will not be able to wait for such a long time. And in such situations, it's best that you screen the parents rather than the child, because the child, we will not be able to, wait for such a long time. He will probably require, he or she will require another transfusion. So just screen the parents. If the parents are normal, then you can suspect that the transfusion has been received for some other reason and it's not thalassemia. But if you find both the parents are beta thalassemia traits, then your suspicion of the child being a thalassemia major becomes increased.
Right, ma'am. Thank you.
Hello, good evening, ma'am.
Good evening. Good evening.
My question is, ma'am, how to differentiate HPFH from delta beta thalassemia?
So HPFH and delta beta thalassemia, if you just look at the red cell indices, usually you will get hypochromic microcytosis with delta beta. Now, these are not, you can say, just rule of thumbs, not very definitive, but usually delta beta thalassemia, the fetal hemoglobin percentage ranges from 15 to 20% or so. The traits for hereditary persistence of fetal hemoglobins, they have a higher percentage of fetal hemoglobin, usually in the range of 25 to 30%. But usually earlier on, we used to do the HbF staining of the RBCs. So seeing the pattern, whether it's pancellular or whether it's heterocellular, you would be able to suspect, but even that is not definitive. So the most important thing is to do the molecular characterization. So if you suspect, you need to confirm by doing the molecular. Now, for delta beta, there is a specific PCR which is there for hereditary persistence of fetal hemoglobin. Again, there is a specific PCR which is there. And if you look at phenotype of the patients, you will find with delta beta and beta thalassemia trait combinations, usually the child will behave like a thalassemia major. But when it is a combination of beta thalassemia trait with hereditary persistence of fetal hemoglobin, usually the patients will behave as thalassemia intermedia. The transfusion requirements are much lower with hereditary persistence and beta thalassemia combinations. But for diagnosis specifically, you need to do the molecular characterization.
Thank you, ma'am.
Hello, good evening, ma'am.
Good evening.
It's really a great session. I have a very few questions to you. Yeah, though you were talking about the hemoglobinopathies, is there any history of Gobar or Portland which can cause the fetal that in India?
No, I didn't get what is your question?
When we are talking about fetal hemoglobin, on
Mhm.
that moment, Gobar 1 or Portland, all those
Oh,
are the,
those are embryonic hemoglobins.
yeah,
So
embryonic hemoglobins.
so they will come in the embryonic period. So
Yeah,
they're not likely to be in an adult. You expect that because adult the alpha globins,
mm,
they are converted in during embryonic life itself. So
yeah.
usually you don't get those in adults.
Okay, ma'am. Uh, and one more question. What do you prefer? Hemoglobin for the identification of thalassemia, which will be the better one, ELISA or HPLC?
ELISA, we don't do.
Okay, ma'am.
Hello. Good evening, ma'am.
Good evening.
Ma'am, this is Dr. Deep here. Thank you for a wonderful lecture. Ma'am, my question is what is the possibility of, like, what will be the differential diagnosis, how to proceed about a case who is non-transfusion dependent, patient is anemic, with RBC indices suspicious of having a microcytic, like thalassemia RBC indices with MCV which is less than 60, and HPLC which comes out to be normal, ma'am. HbA2 being 2.1% and HbF is 3%.
But the patient has received transfusions or no?
No, ma'am, no transfusion.
So if the red cell indices are looking like a thalassemia trait, but the person is not a thalassemia trait, the most common example would be probably alpha thalassemia trait. So the problem with alpha thalassemia trait diagnosis is that only you can do molecular diagnosis. There's no other way of identifying a single alpha gene defect.
Okay, ma'am. Thank you, ma'am.
Good evening, ma'am. Ma'am, my question was that if fetal hemoglobin is more than 40 or 50%, then it loses its linearity on the HPLC machine. So in that case, is there any way to measure the actual percentage of fetal hemoglobin? I'm doing my thesis on fetal hemoglobin inducers in thalassemia. So in what way can I use the machine to determine the exact level of fetal hemoglobin?
The HPLC machine may not be able to give you a very, especially if it's your thesis and all, the very, good percentage of fetal hemoglobin. Basically, because your the fetal hemoglobin adducts that we were talking about, those may not be even counted also in the in your HbF. So usually people who are studying the quantitation of fetal hemoglobin, there are some methods of doing it by flow cytometry, which is supposed to be more accurate than the HPLC percentage, especially when you are trying to monitor patients and then see the percentage of fetal hemoglobin. So you can check the literature of the various ways of doing the exact characterization of fetal hemoglobin percentage.
Okay, thank you so much, ma'am.
Ma'am, what will be the indications of molecular testing in thalassemia?
So very specifically, if you have to do prenatal diagnosis, you need to do. If the patient is on transfusions and you have not been able to characterize properly, then again, you need to do molecular confirmation. Third, in cases of thalassemia intermediates or, some complex situations which are there where you may need to do, or some abnormal hemoglobins where you need to do the confirmation there, would be, I think, specific situations where molecular becomes very important. Usually, otherwise, in regular cases, I don't think molecular is really required.
And ma'am, in prenatal, could you please elaborate, like where specifically should we advise, like in prenatal cases, like antenatal cases?
So when we say antenatal screening, we are talking about a woman who is pregnant, right? So what we do in PGI here is that all the women who come for in the antenatal clinic, we do HPLC for them. Now, wherever we find that combinations may give rise to problem, so you get this beta thalassemia traits, definitely sickle cell traits, hemoglobin E disorders, or say delta beta thalassemia traits, or hereditary persistence of fetal hemoglobin traits. So if we get any of these examples, then we ask for husband screening. So if the husband also turns out to be a beta thalassemia trait, then we counsel them for prenatal diagnosis. So when we say prenatal diagnosis, that means we are going to take a sample of the fetus, which is usually a chorionic villus biopsy, and we do the DNA extraction from there and tell which mutations are there. So like this is how we kind of go about for the molecular kind of diagnosis and offering prenatal diagnosis. And when you're doing any lab which is doing prenatal diagnosis, they also have to have primers which will be able to exclude maternal contamination of DNA, because sometimes you can get some little bits of DNA which may be maternal in origin. So we may need to, completely be sure that there is no maternal contamination before giving out a proper report of the fetal DNA.
Thank you, ma'am.
I want to know, like we were discussing molecular. So in the molecular, which all tests to be sent, like how to decide which investigation, like in a molecular to be sent, like alpha thalassemia, beta thalassemia, or regarding other deciding about what?
Regularly, if it is a case of beta thalassemia trait, then we need to look for beta thalassemia mutations. And the mutations which are there in like India, we have the common 5 mutations which are more common. So most of the labs are actually doing a technique which is known as ARMS PCR, amplification refractory mutation system, where you can find out the design is in such a way that you can find out the specific mutation which is there. Now, we know in India, we have roughly about I think about 60 mutations which have been documented from India. So for these rare mutations, people nowadays are straight away going for beta globin gene sequencing. So beta globin gene just has 3 exons, and there are 2 basic PCRs which can be done, and sequencing can be done. And if you don't have the facility with yourselves, you can outsource it also. And if required, if you get interesting cases and all, we can also help you to solve them if you send the samples to us.
Okay, thank you.
Ma'am, in short, could you just elaborate which are the most common thalassemic hemoglobinopathies that you come across, which behave as thal major and which behave as thal intermedia? Like most common things, like first 2-3 common things that are seen in India.
So for thalassemia majors, usually we have these common Indian mutations which are there, which is the IVS15. IVS15 is all over India, the commonest kind of mutation, G to C. So since this particular talk was not on molecular, this was just on HPLC, I really haven't touched much about the molecular, but thalassemia intermedia is a more complex kind of a situation, because there are, if you read the textbook, you'll find that various combinations can give rise to thalassemia intermedia. So you could get milder mutations, like both mutations could be milder. You could get 2 major mutations, the beta 0 type of mutations, but have in addition alpha thalassemia, which means that alpha gene has got deleted. So making it a little more milder than it should be, kind of. So combinations of, like I told you, hereditary persistence of fetal hemoglobin with beta thalassemia, this combination will give rise to thalassemia intermedia-like syndrome. But delta beta with the beta 0 mutation will give rise to thalassemia major. So what investigations to do actually is completely dependent upon what are what are you suspecting? And for that, the best thing to remember as a, bottom line, which I always tell all my students also, is that please do parental screening, because you will get situations which you can solve only after you have done the parental screening. Because like if you see a child and say, okay, this child has got thalassemia major, but I told you combinations could be delta beta, or it could be 2 beta, or it could be, any of the other combinations which are there. So that you can solve after checking the parents. And like in any of the cases, if the patient has received a transfusion, then again, to solve any case, just do parental screening. So as a bottom line, always remember thalassemia, any problem you encounter, please do parental screening, and then you decide what molecular needs to be done, depending on what combinations you are getting.
Thank you, ma'am, for such a wonderful lecture. I'm Dr. Kadir. Basically, I'm speaking from Pakistan. Thank you. I have two questions. First question is, what is your experience about hemolytic variant of thalassemia minor, which we frequently, see here in our lab? And the second question is, can we separate E from A2 on electrophoresis?
So I didn't understand your first part of the question. You said what? Hemolytic
variant of thalassemia minor. We have seen a lot of cases having A2 around 6 and 7, but the peripheral smear is suggestive of hemolysis, like fragmentation and polychromasia, nucleated RBC, like suggestive of over hemolysis and with low hemoglobin like 6, 7.
With the beta thalassemia trait?
Yes, ma'am.
Then, and have you checked the parents?
Ma'am, unfortunately, we don't have the family screening data, but we are.
No, because, one is that it could be just a thalassemia intermediate type of thing. What about the fetal hemoglobin? Is the fetal hemoglobin on the higher side or is it like normal?
Ma'am, borderline higher side.
So in such situations, look at the reticulocyte count. If the reticulocyte count is high, then also look for unstable hemoglobins, because unstable hemoglobins can give rise to a falsely high HbA2. So whether it's an uncomplicated beta thalassemia trait or whether it is an unstable hemoglobin is something which we need to check probably.
Okay, thank you so much. Ma'am, second part of my question was, how can we separate hemoglobin E from A2 on electrophoresis, gel electrophoresis?
No, we can't. Not with the our electrophoresis system. We cannot, either with HPLC or with the other method which is there, the capillary electrophoresis.
Capillary, yes, ma'am.
Yes, they can separate out, but we can't separate. We generally depend on the clinical phenotype and the parental screening. So over here, we depend a lot on parental screening actually, because without that, it becomes very tough sometimes to characterize what exactly needs to be done.
Okay, thank you so much.
Thank you, ma'am. I think we have really overshot our time. And I really thank you for this wonderful session. And I thank all the participants for their active participation and the wonderful questions that they asked. So it was really a great session. There are many closing statements you want to make?
No, I think I've talked a lot.
Ma'am, Shashi from ISHBT, thank you, ma'am, for such a session. Thank you, Dr. Navajyoti Malli, for coordinating the class.
Dr. Siaram wants to say something.
Good evening, ma'am. Myself, Dr. Siaram, PJ alumni.
Yes.
Yes, pediatric hematology concentrated AIMS Jodhpur.
Yes, yes.
One have query, what we can make mistake from the outside while collecting the sample other than the transfusion. So mistake to be avoided.
One is, I think, just, the sample should be kept in the fridge, even if you can't transport it to the lab the same day. If you keep it in the fridge, that should be fine. I don't think there should be any problem, actually.
Yes.
So
another is, yes, ma'am. Thank you. Another is just like parents always may not available, just like the case discussed by consultant from Pakistan. So in that scenario, how we make diagnosis? Just like we are going orphanage from the Bhavneet Bharti with Bhavneet Bharti, ma'am, in social pediatrics.
Right. For thalassemia trait, it should not be a problem. You just do the HPLC, you'll be able to. But if you get a complex phenotype, it will be very difficult. Because, the molecular for thalassemia is, it has a spectrum. So what you think also actually becomes, if you have the parents, you know what to test. But supposingly, it's a case of delta beta thalassemia with a beta thalassemia trait, and I'm looking for just the beta mutations, I'll get nothing. Or else, what has happened, actually, I had some example of that also, that there was this child who came as a thalassemia major. By the time the diagnosis was made, the mother was again pregnant. And because of the pregnancy, very quickly we had to do all the molecular and everything. In the molecular, the child looked like a homozygous frameshift 4142. But actually, when we looked at the parental data, we realized that it was delta beta thalassemia in one of them, heterozygous, and another, the father was frameshift 4142. So the mother was actually negative for 4142. And that because of that delta beta thalassemia, one allele actually had deletion. So it looked falsely like a homozygous 4142 mutation, but the mother doesn't have the mutation. So, you know, these difficult combinations will come up if you don't have the parental data.
Okay, ma'am. Thank you. So, how common, ma'am, de novo mutation in thalassemia major in India?
Very uncommon, very uncommon. De novo mutations you can get for these uncommon hemoglobin disorders. For the regular ones, it's very uncommon.
Thank you. Thank you.
Ma'am, what technical adjustments do we do for when we receive a polycythemic blood and anemic blood? What technical adjustments do we do in HPLC? Like, do we need to calibrate? I mean, what kind of calibrations that we need to do?
So we haven't really found any problems. I think Nabajit did a thesis on polycythemia. So we really haven't encountered any major problem. Sometimes it happens that your the RBC, the count that we were talking, that it should be within the range of 1 to 3 million. Sometimes it goes a little beyond, but usually we haven't really faced any specific difficulty with either anemic samples or polycythemic samples for HPLC. But usually if the patient has severe anemia, it's a good idea not to interpret the HPLC and say that, you know, let the hematinics be given to the patients, and then you can repeat the HPLC after a few months or so. Because ultimately the report of the HPLC has a genetic connotation. So sometimes, you know, if you have a doubt, it's better to err towards not giving out a diagnosis than committing yourself. Otherwise, the patient will go around with that report.
Thank you.
Right. I think with that, we can close the session with the permission of the ISHBT Secretariat. Can we?
Yeah, we can end the session. Thank you, ma'am. Thank you, Dr. Navjit Malik, for coordinating the class.
Thank you so much.
Bye-bye.
Yeah, just for information, wanted to say that today we had the highest number of participants of 170. Like when I joined, the number of participants was 173 or 74, something like that. Thank you, ma'am.
Okay, bye-bye.